Good morning to all. Today we are going to discuss about few questions and scenarios of tests which are frequently tested in the Part A MRCS exam. So the questions which are usually asked from testicular emergencies or the testicular torsion and the layers of scrotum. So these are frequent questions in the past 3-4 years. I have seen these questions frequently coming up. So we'll be discussing few clinical aspects and theoretical aspects with regard to this in a short module. So before that, we should know about the testes, the routine pathway of testes, and then we should also be knowing about what's undescended testis and what's an ectopic testis. So if you all see here, the when the baby is born or intrauterine, the testis is not an organ in the perineum, right? It's an intra-abdominal organ. So basically, it's in the posterior abdominal wall. As you must be seeing here, it is it's from the intermediate mesoderm. So testis is basically from the intermediate mesoderm, and it's medial to the mesonephros. So that's a question which can be asked future as a part of your embryology. So this testis is attached at its lower pole by the gubernaculum. So this gubernaculum is hormone dependent, and this gubernaculum can help in the descent of the testis. So basically all the gonads in every baby is a ovary, but due to the presence of XY, it forms into a testis in male child, right? So let's go into how the testis becomes an perineal organ. So if you see here, this is the testis, and the testis is guided by the gubernaculum into the perineum, and when it is pulling the testis, the gubernaculum also pulls the peritoneal cavity, and this is forming the processus vaginalis basically. So the processus vaginalis will surround the testis and it will be obliterated, a portion of which will remain around the testis, that's a tunica vaginalis, and if this processus vaginalis is patent, that leads to the formation of hydrocele in a child, right? So this is in the male. So what happens in the female is this gubernaculum will arrest the ovary here, and the remnant of gubernaculum connecting from the ovary to the uterus is called as the ovarian ligament, and the remnant of the gubernaculum which is connecting the uterus to the labia majora, that's called as the round ligament. Okay, so there are two important terms which must be remembered and not confused with each other. The one is a cryptorchidism, which happens when the testis has arrested or stopped in any of the location of its normal descent. Okay, so there is a recently asked question in the MRCS exam. So what's the most common location of undescended testis or cryptorchidism? The answer to that question will be a inguinal canal. So one more scenario is when the testis is not located in its usual pathway, and it is located in the abdominal wall, anterior thigh, medial thigh, perineal. Okay, even though it's rare, but it can be like this. And there is one question called as what's the most common location of ectopic testis, and that's the superficial inguinal pouch. But in the May 2023 exam pathway, we had a specific question asked. Okay, so they asked what is the most common malignancy developing in undescended testis. The answer was seminoma, right? Okay, so these are some basic questions which can be asked. You can expect these questions, but one or two exams they have been asked, but the following things are definitely asked. Okay, so first you must be knowing what are the layers of scrotum. Okay, so the layers of scrotum are given by the very beautiful and a very old mnemonic, that is some damn Englishman called it testis. Okay, so if you see skin, dartos, external spermatic fascia, cremastic fascia, and then the internal spermatic fascia and the tunica vaginalis, and then the testis. But this is not the question which is usually asked. The question which is usually asked, this structure is derived from which? So basically the dartos is derived from the scarpa's fascia, The external spermatic fascia is derived from the external oblique. The cremasteric fascia is derived from the internal oblique. Internal spermatic fascia is derived from the transverse vallis fascia, and tunica vaginalis is the peritoneum. So the questions which have been asked in the past are: external spermatic fascia is derived from, and tunica vaginalis is derived from. These two questions have been asked in the recent. So let's coming to the most important discussion, that's the testicular torsion, right? Testicular torsion, few important catch points which you must be knowing in the clinical scenario is: young age 15 to 25 years, acute scrotal pain, not relieving with medication. So let's just briefly talk about why this is happening. So basically, in this image, if you see, this is the tunica vaginalis which is surrounding the testis. So what happens is, sometimes the tunica vaginalis can be highly invested like this. So this leads to one deformity which is called as the bell clapper deformity. So this can lead to the twisting of the spermatic cord and the development of testicular torsion. Basically the name is testicular torsion, but the thing that's twisting is the spermatic cord. So it's of two types, intravaginal torsion and the extravaginal torsion. So there are, every exam there is one question on testicular torsion, a clinical scenario. So they will give a patient or a child who is coming with pain in the scrotal region. So what will you do? So they will give the options that scrotal ultrasound and scrotal exploration, observation, analgesics. So you have to read the question, you have to understand, and you have to mark the answer. So I will give you one important clue to how to diagnose these scenarios. So there is something called as the twist score. So the twist score consists of 5 components, if you must be knowing. The first component is presence of a testicular swelling, presence of a hard testis, so absent cremasteric reflex, nausea and vomiting, and high riding testis. So it's given a score of 2 and given a score of 1. So you have to match the symptoms which are given in the question, and you have to calculate the score manually. So if it is a score of 0 to 2, then you just observe it. It's very less likely to be a testicular torsion. If it's a score of 3 to 4, then you have to do a USG and call the urologist. If it is a score more than 5, then you have to do scrotal exploration. Okay, so what happens is that most of the time they are giving a scenario. Even in the May 2020 there was a confusing scenario asked. So you basically have to see through this twist score and calculate it manually, and if the score is coming more than 5, most of the time you will do a scrotal exploration, and if it is less than 5, you will be doing ultrasound. So whenever you are doing this scrotal exploration, one thing that you must keep in your mind is that the opposite side should be also be fixed. So we are using the transverse incision or the median raphe incision, and the opposite testis will also be fixed. Okay, so there is one new question which is being asked nowadays. That question is the presence of the similar features of testicular torsion, but there is a presence of a blue dot in the scrotum. So this is known as the torsion of testicular appendages or the Morgagni appendages. Okay, so this sums up these two clinical scenarios, the layers of scrotum and testicular torsion. So you can definitely expect 2 questions from this. Thank you.